Good afternoon, and welcome to the first annual Long-Term Care Survey Year in Review presentation. I am Thomas Hamilton, Director of the Survey and Certification Group at the Centers for Medicare and Medicaid Services, also known as CMS. Some of our nation's most vulnerable citizens reside in long-term care facilities. It is through the hard work and dedication of nursing home surveyors such as yourselves that the nation's nursing home residents can be assured of receiving the quality of care they deserve. Through the provision of information and educational outreach, we at CMS hope to fulfill our goal and commitment of providing full support to surveyors who are evaluating nursing homes. The Division of Nursing Homes has taken the initiative to provide that very support, beginning with today's broadcast as one such outreach tool. In today's presentation, we hope to ensure that each nursing home surveyor is aware of the important policies and guidance regarding nursing home surveying that CMS issued during fiscal year 2005. Today's broadcast will cover surveyor guidance that has been issued in the course of the past year. Examples include survey guidance for pressure ulcers, incontinence, catheters, the role of medical directors, electronic signatures on the MDS, abuse and neglect, and complaint tracking and management. In addition, we will describe some projects that are unfolding now or are on the horizon for implementation in the near future. Examples include the Quality Indicator Survey, or QIS, the new Medicare prescription drug coverage, surveyor guidance regarding psychosocial outcomes, and the new influenza and pneumonia immunizations regulation. I hope that you find today's presentation useful, and I encourage you to visit CMS's survey and certification website for more information at www.cms.hhs.gov/survey-CERT. Thank you for joining us today, and thank you again for your continued commitment to improve the delivery of services and support to residents in our nation's nursing homes.
Good afternoon. I'm Beverly Cullen with the CMS Division of Nursing Homes. Welcome to our first annual Year in Review broadcast.
And I'm Karen Shaneman, also with the Division of Nursing Homes. During today's program, you'll hear about projects our division completed in fiscal year 2005, as well as those we're currently working on. For this broadcast, instead of having live questions and answers, we solicited questions from our state and CMS regional office surveyors, which we used in crafting the segments of today's program.
Our division develops guidance to assist surveyors of nursing homes with survey, complaint, and enforcement processes. Much of the guidance that you will hear about today is initially released in survey and certification letters, otherwise known as S&C letters. They can be found at the CMS website page located at www.cms.hhs.gov/survey-cert/.
Yes, Bev, as our viewers can see on screen, this website page has a great deal of information for both surveyors and providers. Now, if you take a look further down on this page, you'll see that there is a link to the survey and certification letters. On your screen now, you should see the S&C letters site, where letters containing guidance, such as you'll hear about today, can be found by the fiscal year during which they were issued. Note that each letter is assigned a number that's associated with the fiscal year and the order in which it was issued. The title will provide you with the subject of the letter and what type of provider it's applicable to, such as nursing homes. Our new guidance eventually is issued through a transmittal, which is placed on a different web page. At this site, www.cms.hhs.gov/manuals/transmittals/date_DSC.ASP, there is an explanatory transmittal sheet that notes what was changed, deleted, or added. This is followed by an attachment of the revised text. This is a convenient way for individuals that already have our state operations manual to find out what parts have changed. In addition to the transmittals page, the new text is placed into the actual State Operations Manual on the manual's webpage, which is www.cms.hhs.gov/manuals/107-SOM107-index.asp. Much of what our division writes becomes part of either Appendix P, the survey process, or Appendix P, the interpretive guidelines. There are some revisions which go into chapters of the State Operations Manual rather than the appendices. The Table of Contents page for the State Operations Manual shows a list of the chapters followed by the appendices. The transmittal sheet will tell you which part of the manual has changed.
Thank you, Karen. Our division published several S&C letters this last fiscal year. Some of these letters related to Life Safety Code issues. Jim Merrill, our division's Life Safety Code specialist, will now provide an update. Jim?
The Centers for Medicare and Medicaid Services has published several S&C letters related to Life Safety Code issues over the past fiscal year. These letters contained information that is to be used when surveying facilities using the 2000 edition of the Life Safety Code. Also, in the past year, we have adopted 2 new regulations. Number 1 allows the use of alcohol-based hand rubs, ABHRs, in the corridors of healthcare facilities, and number 2 requires that nursing homes not fully sprinklered in accordance with NFPA 13, standard for the installation of sprinkler systems, to install battery-operated smoke alarms in resident sleeping rooms and other areas where residents gather on a regular basis. First, let us take a look at S&C Letter 0525, issued April 14th of 2005, entitled Nursing Homes, Adoption of New Fire Safety Requirements for Long-Term Care Facilities, Battery-Powered Smoke Detector Installation. This letter announced the publication of a new fire safety requirement for long-term care facilities and only long-term care facilities. The regulation requires non-sprinklered facilities to install battery-powered smoke alarms in resident sleeping rooms and common areas such as dining, activity, and other meeting rooms where residents gather. This would not apply to areas exclusively for staff use and where residents are prohibited from entering. A facility that is partially sprinklered or one that does not have a sprinkler system that provides complete coverage in all areas, as required by NFPA 13, is also required to install battery-operated smoke alarms. Installation of these alarms is to be completed by May 24th, 2006. Facilities are required to properly maintain installed smoke alarms and to document maintenance activities. Facility fire plans are also to be updated to include facility staff response to one of the individual smoke alarms sounding. Now, let us take a look at S&C Letter 0533, issued June 9th of 2005, entitled Multiple Providers, Adoption of a New Fire Safety Amendment for the Use of Alcohol-Based Hand Rubs, ABHRs. This amendment to the regulation is applicable to all healthcare providers such as hospitals, ambulatory surgical centers, nursing homes, religious non-medical healthcare institutions, programs of all-inclusive care for the elderly, PACE facilities, critical access hospitals, and intermediate care facilities for the mentally retarded. The letter announced the publication of this amendment to the Life Safety Code that allows the installation and use of alcohol-based hand rub dispensers in corridors of healthcare facilities. The letter also outlines precautions to be observed when installing these dispensers in corridors, such as the minimum width of the corridor and preventing access to the dispensers by vulnerable populations such as residents with dementia, children, and patients with psychiatric disorders. Lastly, S&C Letter 0538 was issued July 14th and is titled Clarification of Life Safety Code Issues in Nursing Homes. This letter addressed several Life Safety Code survey issues, including wardrobe, closet sprinklering requirements, exit discharge surfacing requirements, and canopy sprinkler requirements. The letter reiterates the requirement that sprinklers are required in clothes closets and are not required in wardrobes, which are considered pieces of furniture. Exit discharges to a public way are required to be usable in all situations and weather conditions, and may be required to be surfaced in some way to enable residents using wheelchairs, walkers, or other assistive devices to be able to use the exit discharge to leave the facility in an emergency. The third issue addressed by this letter concerns the requirements for installing sprinklers and canopies. Basically, sprinklers are required when a canopy exceeds 4 feet in width and is constructed of combustible materials. In addition, during the past fiscal year, we have increased the number of fire safety or life safety code look-behind surveys of nursing homes. We have used a combination of regional office surveyors and contractor surveyors to complete this work. These surveys are completed within 60 days of the survey completed by the state agency. If any deficiencies are found during these surveys, a 2567 Statement of Deficiencies is prepared and sent to the facility for corrective action. The number of these surveys completed during fiscal year 2005 was approximately 800. Some of the most common deficiencies found were in the areas of hazardous area separation, smoke barrier construction, corridor doors, and the maintenance of fire alarm and sprinkler systems. We anticipate continuing these random look-behind surveys this fiscal year. For more information and to view the S&C letters mentioned during this program, please visit the CMS Survey and Certification website at www.cms.gov/Medicaid/survey-cert. This is James Merrill reporting live from Baltimore.
Thanks, Jim. The next project that has produced results during the 05 fiscal year is the development of revisions to the interpretive guidelines and severity guidance for certain key regulatory tags. CMS has contracted with the American Institutes for Research to assist us in the development of these revisions. The leads for this project are Bev and myself. Bev, how about letting our viewers know how this project is progressing?
Sure, Karen. We selected approximately 12 tags or groups of related tags for revision in this project. In order to develop our guidance, we have convened panels composed of nationally recognized experts and regional office and state agency surveyors. Our expert panelists have provided us with information to enhance our guidance, which will help promote consistency in the way that surveyors across the country evaluate the care and services at these particular tags. We have also developed investigative protocols for some of the tags and severity guidance for all of the tags included in this project.
Bev, which of these tags are final now?
Karen, during the last fiscal year, 2005, we have completed the work on the following tags. For F314 pressure ulcers, the guidance was completed and issued in November of 2004 and has been incorporated into the State Operations Manual. Essentially, this guidance expanded the information available to surveyors for evaluating pressure ulcer care, including prevention, assessment, and interventions. In addition, the 1999 investigative protocol was revised, and specific guidance was added for a determination of severity for a deficiency at F314. The intent of this revised guidance is to equip surveyors with the resources to decide whether a pressure ulcer was avoidable and whether the facility's efforts in preventing and intervening were adequate. Susan Jocelyn, a nurse consultant in our division, has been assigned as lead for this tag. A second tag area that is final is F315, which addresses catheters, urinary incontinence, and urinary tract infections. This guidance was completed and issued in June of 2005 and has been incorporated into the State Operations Manual. We also developed a new investigative protocol and severity guidance for deficiencies at this tag. This guidance makes the point that incontinence should not be considered just a normal part of aging. Instead, facilities need to determine for each resident who is incontinent the root cause of their incontinence in order to ensure that appropriate interventions are put in place. Rosemary Dunn, a nurse consultant in our division, has been assigned as lead for this tag. We also have several tags that are in various stages in the CMS clearance process, including F520, Quality Assessment and Assurance. The focus of the new guidance developed at this tag is to assure that facilities have a committee in place that functions to identify quality issues, to develop corrective action plans, and to monitor the success of the corrections. Linda O'Hara, a nurse consultant for our division, has been assigned lead responsibility for this tag.
Yes, Linda's also the assigned lead for the medical director tag at F501. Linda's in our newsroom now with breaking information on the status of this tag. Linda, how about providing our viewers with some insight as to why CMS chose F501 to revise?
Sure, Karen. As you know, nursing home residents' medical care has become increasingly more complex. We wanted to make sure we emphasize for surveyors the importance of the medical director's role in the development of the facility's policies to address care for this more complex population. The type of care issues you see today may include residents with end-stage renal disease, those who require hospice services, or even IV therapies. The increasing complexity of medical issues and the availability of new therapies and treatments means a facility's care policies and procedures need to change to keep up with current standards of practice. And the medical director's oversight of this is crucial to the facility being able to provide the best quality care that each resident needs. The medical director can be a great resource to the facility staff and educational opportunities on the most current standards of practice. In addition to the medical director's role in keeping policies and procedures up to date, he or she is in a good position to be a liaison between the facility and the attending physicians and other professionals who provide services in the nursing home. Coordination of medical care is specified in the medical director regulation as one of the responsibilities of the medical director.
It sounds like the medical director's close involvement with the facility is crucial. So how was the new interpretive guidance developed?
CMS convened a panel of experts to assist us in developing this guidance. The panel included medical directors, administrators, and state and regional office survey participants, as well as CMS central staff who are responsible for the guidelines and survey process. Panel members provide current information about aspects of the medical director role that enabled CMS to develop this new guidance and a new investigative protocol that surveyors can use to evaluate each facility's compliance with the medical director regulation. We've also developed severity guidance for the tag that explains when surveyors are to select various levels of severity for deficiencies at this tag.
Okay, so is this new guidance final?
Karen, the guidance for medical director was issued as an advanced copy and released within a survey and certification memo on June 9th, 2005, with an implementation date of November 18th, 2005. Viewers may find this memo and the advanced copy at www.cms.hhs.gov/Medicaid/survey-cert/SC0529.pdf. We have provided this advanced final copy in response to a request by state agencies who want time prior to the actual implementation date for surveyor training on how to use the new guidance. We have also developed a training tool to assist the state agencies in their training. This tool is in PowerPoint format and will be available to each state agency and regional office. We recognize that nursing home providers also have an interest in training their staff on the new guidance, and this information will also be available for their use. The guidance and the PowerPoint tool will be placed on our CMS survey and certification website as soon as it has been cleared.
Linda, thanks for all this information on our new medical director guidance. Now, Bev, you were in the middle of this listing of all the tag projects we worked on this past year. What other tags would you like to discuss?
Well, Karen, you are the lead for tags F248 and 249 for activities in the Activity Director. At this time, you have the guidance in the clearance process.
Yes. The work on these two quality of life tags is almost finished, and I'd like to thank our expert panel for their efforts in this project. The Activities Tag 248 specifies that the facility is responsible, not just the Activities Department, for providing each resident with activities to meet their interests and preferences. And this doesn't just mean from 9 to 5 on weekdays. Having something interesting to do is a key part of quality of life, and the facility should be determining, as part of their resident assessment, what each resident's preferences are and developing care planning to meet these interests. We've added guidance about the many ways that activities can be adapted for residents with various physical or mental issues, and we've also provided an investigative protocol. During the development of this guidance, we determined that outcomes to residents from a deficiency at 248 would likely be psychosocial outcomes. Rather than write a severity guide that was only applicable to activities deficiencies, we decided we needed an addition to our general severity guidance that would cover psychosocial outcomes to residents from deficiencies at any tag, whether quality of life or quality of care. So Jeannie Nitch of our division and I convened a panel of psychosocial experts and surveyors. This team assisted us to develop the Psychosocial Outcome Guide. This guidance has gone through CMS clearance and will be released in a survey insert letter just as soon as we develop a PowerPoint training tool to go along with it. We're also beginning work on satellite broadcasts for both activities and the Psychosocial Outcome Guide. Bev, what about the rest of the tags in this project?
Well, we have several tags that are in various stages of development, including at F309, Quality of Care, we have decided to include guidance on pain management and on palliative and hospice care. This topic is of such great interest to us and is so multifaceted that 4 of us are co-leading the development of this guidance. Besides myself and you, Karen, Jeannie Nitch is included, as well as Mavis Connolly from our division that handles hospice issues. Jeannie Nitch, along with Jim Merrill, our Life Safety Code lead, are co-chairing the development of guidance for tags 323 and 324, which will be combined into one tag F323 for accidents and supervision. I'm in the process of working with the expert panels to complete the guidance and combination of the tags F329, 330, and 331 under one tag, F329, for unnecessary drugs. And I'm also working with the expert panels to complete the guidance and combination of tags for the entire pharmacy section. So we will end up with 3 tags: F425, Pharmacy Systems, F428, Medication Regimen Review, and F431, Medication Storage and Reconciliation of Scheduled Medications. In our office, Deborah Swinton-Spears, nurse consultant for our division, has been assigned the responsibility as tag lead for unnecessary medications and pharmacy services. Elisa Overgaard is the tag lead for F325, Nutrition, and for F371, Food Sanitation. That guidance is in the process of being developed for these tags. And finally, we have decided to convene an expert panel to discuss and develop guidance for the tags at F223 through F226, which include prohibiting abuse, neglect, and mistreatment of residents, and misappropriation of funds, and investigating and reporting. Jeannie Nitch is chairing this expert panel, and several staff from the division will also be involved, including Kathy Lockery, Elaine Liu, and myself.
This project has certainly involved a lot of panels and development activities. How about explaining what we're doing about the issuance of all this new guidance?
Karen, after we issued the pressure ulcer guidance, state survey agencies requested that we provide more notice of new guidelines in order to allow them to notify and train surveyors before the date of implementation. So, we changed our process to include providing an advance copy of the guidance, which has gone through the CMS clearance process and is considered to be a final copy. For each tag, the advance copy is attached to a survey and certification letter, which goes to all survey agencies and our regional offices. It is also placed on the CMS Survey Insert webpage. We are allowing at least a couple of months between when the advanced copy gets posted and the implementation date. As Linda mentioned earlier, we currently have an advanced final copy of the guidance for the medical director tag F501 with an expected issuance date in November. Karen, how about explaining how the project addresses the educational components for the survey staff?
Sure. We've been working with our contractor on developing a PowerPoint training for each tag. As each tag goes out with a survey insert letter, we will attach the PowerPoint file that training staff can use to train all the surveyors prior to the implementation of the new guidance. In addition, we've selected some of the tags for satellite broadcasts. Earlier, I mentioned that we are working on broadcasts for activities and the psychosocial outcomes guide, and we are planning others in the coming months. We're going to follow a similar format for each show under the general title of CMS Nursing Home Journal. Volume 1 was the pressure ulcer show, and Volume 2 was the broadcast on incontinence. Our internet streaming site, www.cms.internetstreaming.com, will provide notice of each show and will also be the site where the shows can be viewed, either when they're broadcast or up to a year afterwards. Bev, do you have any other comments about this tag revision project for our listeners?
Karen, I just want to let our surveyors know that this guidance has been developed using leading experts in the field in order to provide the most up-to-date information and resources about current standards of practice. The use of this guidance should go a long way in ensuring more consistency in the way we apply the survey process and how we assess for compliance. We also understand the importance of this guidance for providers and advocates as well, as we are all working to assure that nursing home residents receive the care and services that they need.
Thanks, Bev. Now let's turn to another issue that has received a lot of attention in our division during the 05 fiscal year. In today's fast-paced nursing home environment, many providers are using computers for record keeping, and they have been asking us about the possibilities of using electronic signatures. We've been receiving questions, and we've recognized the need to provide guidance on this issue. Rosemary Dunn, nurse consultant in our division, has been working on this issue. Rosemary, what's happening?
With the implementation of electronic transmission of the Resident Assessment Instrument Minimum Data Set 2.0, also known as the MDS, providers of long-term care facilities have requested that CMS authorize to use electronic signatures on the MDS and the resident's clinical record. The demand for the use of electronic signatures and requirements to retain hard copies of the MDS and the resident's clinical records has raised operational issues and concerns by both facility staff and authorized reviewers. As a result, on January 13, 2005, Thomas Hamilton, the Director of Survey and Certification Group at CMS, sent a letter identified as Survey Insert 05-14 to regional office and state agencies personnel clarifying the use of electronic signatures. This guidance was intended to replace S&C Letter 04-46 dated September 9, 2004. The intent of this clarification was to inform Medicare and Medicaid certified long-term care providers who have the capability to implement electronic signatures for their MDS documentation that they may do so whether or not the clinical record is entirely electronic. Facilities that have the capability of implementing electronic signatures are required to have safeguards and security measures protecting the use of an electronic signature by anyone other than to which the electronic signature belongs. In addition, facilities must have written policies in place regarding its use that ensure that access to a hard copy of a resident's clinical record is made available to surveyors and others who are authorized by law to view such, as well as ensuring that those who are authorized to sign electronically are identified accordingly. Long-term care facilities that are not capable of maintaining the MDS signatures electronically must adhere to CMS requirements addressing the need for either a handwritten copy or a computer-generated form. All state licensure and state practice regulations continue to apply to certified long-term care facilities. Where state law is more restrictive than federal requirements, the provider needs to apply the state law standard. However, some states have specific requirements regarding the use of electronic signatures. A few states do not address electronic signatures in their statutes or regulations, but may permit the use of electronic signatures with approval from physical intermediaries or state authorities. In summary, the skilled nursing facilities and nursing facilities may implement the use of electronic signatures for clinical record documentation, whether or not the clinical record is entirely electronic. This includes the minimum data set, provided that state and local laws and the long-term care facilities policies permit. The effective date for implementation of this clarifying policy was February 13, 2005. For more information, please view S&C Letter 05-14 on the CMS Survey and Certification Letters website at www.cms.hhs.gov/Medicaid/survey-cert. I'm Rosemary Dunn, reporting live from Baltimore. Karen and Bev, now back to you.
Thanks, Rosemary. Stay tuned to our broadcast for more information on complaint management guidance, abuse and neglect guidance, and the forecast for fiscal year 2006. But first, a message about one of our special projects.
Good afternoon. My name is Fred Gladden, and I am a technical assistant with the Division of Nursing Homes at CMS. I would like to provide a brief update of our Quality Indicator Survey, or QIS, demonstration. This demonstration applies only to nursing homes certified to participate in the Medicare and/or Medicaid programs. Essentially, the QIS changes the way surveyors gather information during the survey process. In December of last year, CMS coordinated a presentation by our contractors of the Quality Indicator Survey. The presentation was held in Baltimore. All of the state survey agencies were invited, as well as national provider organizations and advocacy groups. Following the presentation, 25 survey agencies expressed an interest in being part of the QIS demonstration. In June of this year, 5 states and 2 alternates were selected for the demonstration. The demonstration states include Connecticut, Ohio, Kansas, Louisiana, and California. Florida and Illinois were selected as alternates. Phase 1 of the demonstration involves Connecticut, Ohio, and Kansas. Training of one 4-member team of surveyors, supervisors, and an IT lead occurred in Denver the week of September 26th of this year. The training was conducted by contractor staff from the University of Colorado. The classroom training will be followed by training surveys in each state before beginning surveys of record. In November of this year, training of the second team from each of the 3 states will occur. Phase 2 will involve training the remaining 2 demonstration states along with staff from the alternate states. The QIS demonstration is not statewide. Again, 2 core survey teams of 4 surveyors each comprise the QIS demonstration in each state. As such, it is unlikely that most providers will receive a QIS standard survey. It is also important to point out that certification regulations remain unchanged and that the interpretive guidance is basically unchanged. In addition, the survey team decision-making process has not changed. What is different is the manner in which information is gathered to assess compliance. An evaluation of the QIS demonstration will be conducted by APT Associates and 2 subcontractors. The evaluation will occur over the course of approximately 12 months, followed by a report of the QIS evaluation in early 2007. At that point, CMS management will make a decision whether to proceed with national implementation.
Welcome back, everyone. In January of 2004, CMS implemented the first national electronic system for tracking complaints. This system tracks complaints from the intake process through the resolution process against Medicare and Medicaid providers and suppliers. Let's check in with Elaine Liu and Kathy Lockery of our division to review the year related to complaint policy, procedures, and system improvements. Hello, Elaine and Kathy. It's nice to have you both with us today.
Yes, thank you. This is a good time for us to review for our viewers the survey and certification letters released during the last fiscal year related to complaints and complaint management. Last December, we released a survey and certification letter about how state survey agencies respond to referrals. We know that besides the survey agency, other public agencies or organizations receive information and perform investigations of nursing homes. These entities might include the Office of the Coroner or Medical Examiner, quality improvement organizations, law enforcement, the Ombudsman's Office, protection and advocacy systems. These public entities forward information to the survey agency if there are concerns about the health and safety of nursing home residents. As always, the survey agency gives appropriate consideration to these referrals to assure that nursing homes are providing adequate care and services to their residents. We want to make sure that referrals alleging noncompliance with the federal nursing home requirements are tracked in the Aspen Complaints Incidents Tracking System, which we refer to by the acronym ACTS, ACTS. For reporting purposes, these cases are entered as complaints into ACTS. For example, for a referral from the coroner's office, states would check coroner under the source field for the intake in ACTS. In summary, survey agencies acknowledge the receipt of the referral and assess it to determine the severity and the urgency, that is the priority of the allegations, so that appropriate and timely action can be taken. The survey agency would conduct an investigation, if applicable, and provide a written report of the investigation findings to the referring entity and the investigated nursing home.
That's right, Kathy. And don't forget that we sent an administrative letter to the state survey agencies in June. This letter includes an example of how a state survey agency worked with another agency to implement a system that assured that cases shuttled between them would not fall through the cracks. Karen, in thinking about communication, it makes me think about how we're using electronic systems to communicate with one another. To that end, I would like to tell our viewers about another S&C letter that was released this past May. S&C 0527 provides data entry guidelines for Aspen Central Office and ACTS. It is comprised of three main components. First, it provides timeframes in which survey visit information should be entered into ACO for all Medicare and Medicaid certified provider supplier types. Second, it provides timeframes in which complaint and incident data should be entered into ACTS. I want to emphasize that all of these timeframes serve as interim, and I stress interim guidance for state survey agencies. We appreciate all of the comments we received on them. They will assist us in developing the final guidelines, as well as developing a means for measuring whether they are being met. Lastly, this S&C letter includes revised definitions of the required fields in ACTS. Unlike the timeframes, these definitions are final and should be used by your state agency in inputting data into ACTS.
Elaine, since we're telling our viewers about data entry into ACTS, why don't you take the time right now to tell them about the national reports that CMS is able to generate from the CASPER system that draws on data entered into ACTS?
Sure. This past year, CMS started to copy data from ACTS into a national repository, also known as CASPER. CASPER allows us to get a big picture of what's happening in terms of complaints, since investigating complaints can be a significant piece of your workload. So far, the reports posted online can assist your state agency in answering the following questions. How many complaints have been received in the last year, and how are these complaints prioritized? Both of these questions can be answered with the report you see now on the screen. In addition, the following questions can also be answered. How long does it take to process the complaints prioritized as immediate jeopardy? How many complaints lead to a federal deficiency? And how many complaints with an allegation of abuse were received in the last year? Besides these big picture reports, there are also detailed reports that provide information about which complaints are included in the summary reports. To access these reports, you can go to the website you see on the screen, or they can also be accessed through the Keys to Success website. Kathy, I will turn things back to you to tell us about another S&C letter related to complaint management.
Thanks, Elaine. This past June, we issued a survey and certification letter with number S&C 0531. It provides information to support survey agency activities during the intake of complaint allegations against a nursing home. I believe that everyone would agree that the collection of information from complainants during the intake process is essential to effectively managing complaints. In our work with states, they have shared with us different approaches and how they collect information during the intake process. We compiled this information, added to it, and sent it to all states so that everyone could benefit. This memo, S&C 0531, includes a list of different types of questions to support the intake of nursing home complaint allegations. It includes questions to support intake staff in collecting as much information as possible from complainants when discussing concerns about the care and services provided in nursing homes. These questions are not an exhaustive list, but illustrate the types of information useful to collect during the intake process and how the information can be useful. Well, Karen, that's all from Elaine and I. However, before leaving, we would both like to take a moment to thank those states and CMS regional offices that have worked closely with us in the development and implementation of the complaint system, ACTS, and the supporting policy and procedures related to complaint management. We appreciate the fact that folks who already have full workloads took the time, countless times, to review and comment on draft materials, to respond to questions and requests for information from CMS, and regularly participate in scheduled conference calls. We are grateful for this support and assistance. It has made the program better. Now back to you, Karen.
Thank you, Elaine and Kathy, for letting our viewers in on all the work that's been going on in this area.
In CMS's Division of Nursing Homes, Jeannie Nitsch, a social worker, has worked for many years on issues related to abuse and neglect of residents in nursing homes, as well as other quality of life issues. Jeannie, I believe you have some information regarding an important memo about nursing home reporting requirements for abuse and neglect.
Thank you, Bev. That's correct. The memo that Bev is referring to is S&C-05-09, and it was released December 16, 2004. We wrote this memo in order to respond to requests from the state survey agencies for clarification about a facility's obligation to report allegations and the results of investigations of alleged violations. These violations include mistreatment, neglect, and abuse, including injuries of unknown source, and misappropriation of resident property. With input from the state survey agencies, we released guidance that addresses the following 3 issues: when alleged violations should be reported, to whom alleged violations should be reported, and the definition of injuries of unknown source. Specifically, for the first issue, when alleged violations should be reported, the guidance clarifies that immediately means as soon as possible, but must not exceed 24 hours after the discovery of the incident. For the second issue, to whom alleged violations should be reported, the guidance clarifies that the alleged violations and the results of all investigations must be reported to the administrator of the facility, other officials in accordance with state law, and the state survey agency. Further, it is clear from the federal regulation that reporting to the state survey agencies is not optional. Also, the memo clarifies that the phrase, "in accordance with state law," modifies the word "officials" only. It does not authorize the state to define what should be reported or the timeframes for reporting under the federal requirement. The third issue is the definition of injuries of unknown source. An injury should be classified as an injury of unknown source when both of the following conditions are met. First, the source of the injury was not observed by any person, or the source of the injury could not be explained by the resident. And second, the injury is suspicious because of the extent of the injury, or the location of the injury, or the number of injuries observed at one particular point in time, or the incidence of injuries over time. In this guidance, we also remind the states that when assessing whether facilities meet the federal requirements, the federal definitions for abuse, neglect, and misappropriation of resident property must be used.
Jeannie, thank you for reviewing this information on such an important set of issues.
You're welcome, Bev.
Well, Karen, we sure have heard a great deal of information about the projects our Division of Nursing Homes has been involved with over the past year. We've sure been a busy bunch.
That's definitely true, Bev. Rain or shine, we've been plugging along. And speaking of the weather, we've got Cindy Gronke, the director of the Division of Nursing Homes, in the weather room with a forecast of some projects that the division's working on for this fiscal year, 06. Cindy, what's the forecast?
Well, Karen, we've got a great-looking forecast for this year. As many of you know, the Medicare Prescription Drug Improvement and Modernization Act of 2003 provides an important new benefit to Medicare beneficiaries. The Medicare prescription drug plans take effect this winter, beginning January 1st, 2006. So, the Division of Nursing Homes took the initiative to address any issues before the drug plans move in. That initiative resulted in a satellite broadcast, the Medicare Prescription Drug Plan Impact on Nursing Homes. The broadcast is scheduled to air at 1 o'clock Eastern Standard Time on November 4th, 2005. During the broadcast, viewers will hear a considerable amount of information on the benefit and the impacts the new drug plans may have on nursing home facilities, their residents, and the fulfillment of regulatory requirements. I think surveyors will be impressed with the amount of information they will gain from this broadcast. Now, just a few weeks ago, on October 7th, we had the new regulation on immunization standards for long-term care sweep in. The regulation requires long-term care facilities to provide each resident the opportunity to receive the influenza and pneumococcal immunization. As a result, nursing home providers are expected to educate their residents about the immunizations and provide those immunizations unless they are medically contraindicated or they're refused by the resident. Although the regulation hit on October 7th, surveyors will not begin to survey for this specific requirement until its implementation in the warmer months of June of next year. By that time, CMS will have developed a new immunization quality measure that will be based upon the new MDS Section W of the immunization status. Like other quality measures, this measure will be used in the survey process. In addition, a new tag, F334, and an accompanying guidance and investigative protocol is currently being developed and will be released by June. I encourage viewers to visit the CMS Influenza website for more information. If you missed that broadcast, you can still view it until next September of next year through the CMS Internet streaming site. And as you know, as we move into the cooler weather of the fall, our viewers across the nation will be seeing a brand new guidance on the psychosocial outcome severity to assist them in determining the severity of a deficiency for psychosocial outcomes. Right now, the guidance is complete, but we're awaiting its release until the educational products that complement the guidance are complete and cleared. Also, sweeping in during the cooler months of 2006 for all states is the civil money penalty grid. CMP amounts can vary greatly due to many factors, including the history of facility noncompliance, seriousness and scope of deficiencies, the number of deficiencies, and financial condition. CMS now recognizes that as each case is unique, the existing process of determining CMP amounts leaves maximum discretion to states and regional offices. This results in widespread disparities, making it important for there to be greater national consistency. As a result, a joint federal-state work group has developed a national CMP grid. The grid is currently in the CMS clearance process and is expected to be issued during the first half of 2006. Coming early this fall is a survey and certification memorandum on past noncompliance. In fact, we expect the effective date to be November 1st of this year. This will replace policies that are currently in the state operations manual on the issue. The memorandum will provide CMS policy on establishing criteria for citing past noncompliance guidance for enforcement action, determining whether correction has occurred, and information on the changes in CMS's data systems. And finally, continuing to move across the nation's states this year, and I mean throughout the entire year, is a front on the Government Performance and Responsibility Act, also known as GPRA, for nursing homes. These goals include decreasing the prevalence of unnecessary physical restraints in nursing homes and decreasing the prevalence of pressure ulcers in nursing homes. For 2006, the GPRA goal target for restraints is 6.4%, and for pressure ulcers, it is 8.8%. CMS, in conjunction with its regional offices and state survey agencies, is continuing to strategize for ways to continue reductions in the prevalence of pressure ulcers and restraints in nursing homes. Those reduction efforts consist of focusing surveyor attention on facility practices, encouraging facilities to work with quality improvement organizations on reduction strategies, and other CMS-produced guidance, data, and information. For pressure ulcers specifically, there is a pressure ulcer prevention and treatment pilot that's currently underway. This pilot is an attempt to improve the accuracy of pressure ulcer citations and decreases the prevalence of pressure ulcers. Well, that's it for now. Karen and Bev, back to you.
That sure sounds like a sunny forecast for the coming fiscal year. Thanks, Cindy, for the update.
Well, that's all for our show today. I hope this update has helped our surveyors to keep up to date on our new guidance and on our projects.
We intend for this to be the first of a series of end-of-year broadcasts by the Division of Nursing Homes. Thanks for joining us today and for your commitment to making sure residents of our nation's nursing homes have the best possible quality of life and quality of care.